Hello and welcome to Spear Medical Education. I'm Eric, and today we're going to be looking at pharmacology. So this makes up the first in our sort of Pharmacology 101 series. So it's just introducing you to some of the really basic concepts of pharmacology and some of the critical information that we need to know when handling drugs around patients. So we're going to build on this and eventually start looking at specific drugs and how they work and things like that. But at the moment, we're just going to try and really sort of lay some good foundations for our practice. So we start off where we always start off with any sort of pharmacology or any drug handling, and that's the sort of safety aspects. So the 5 rights of drug safety is what we call it. So that is that we've got the right patient, we're giving them the right drug, the right dose, via the right route, and is it the right date, as in is the drug in date. And a little bit that I add onto the end there, is there any damage, discoloration or debris in the vial of the drug, or to the package, or damage to the packaging of the drug, or discoloration of the medicine that you're about to give. So we want to know, is the patient the right patient? So if we're giving this drug independently, obviously it's our patients, that's where our clinical decision making and reasoning comes into play. If it's a drug that's being prescribed to somebody, we're making sure that the prescription for that drug matches the patient that's expecting to receive it. Obviously we're going to check the drug, so is it the right drug? And actually, certainly in pre-hospital practice, one of the things that I've taken to doing is, rather than sort of just looking at the drug myself and saying, yep, that's aspirin or that's tranexamic acid, actually getting somebody else to look at it with me. So there's a couple of ways you can do this. The traditional one is to show the person, the other person, the drug. So let's say aspirin, and say, this is aspirin, and then get them to sort of confirm that back to you and agree with you. Yeah, that's aspirin. Actually, what we found is one of the safer ways of doing it is just saying to the person, what is this drug? And the person doesn't have to be medically trained. It can be a relative or a helpful bystander, that you can just say to look at the drug itself. So you're looking at it and it says aspirin. In your head, you're saying this is aspirin. And then you're showing it to the other person and saying, what is this drug? And hopefully what you're going to hear back is that response, aspirin or whatever drug it is that you're going to give. You can also do the same with the expiry date as well. Ask the person, what is the expiry date? We're then going to check, are we giving the right dose? So again, that's either based off our own clinical judgment or the sort of the prescription that the patient's being given. Is it going via the right route? So intravenous, intraosseous, subcutaneous, etc. The date, is it right? So has it expired or not? And then, like I said, obviously any damage, discoloration or debris. So that's our sort of like principles of safety when we're handling medicines and we're about to administer it to a patient. And regardless of the circumstances we find ourselves in, we should always strive to be that safe and that thorough with drugs. Next, we're going to look at, just over here, is documentation. So just very, very quickly, this is how we sort of document doses of drugs. And again, it's to try and ensure that we're doing it in a consistent way, and what we write means the same to everybody in the sort of medical field and sort of that's going to be involved with this patient's care. So what we say, if there's any quantity of drug that is over a gram, then we write it as grams. So if we was going to give somebody 4 grams of a particular medicine, it'd just be written as 4 grams. If the dose is below 1 gram, then we use milligrams. So if we was going to give someone half of a gram, that would be 500 milligrams. And instead of writing 0.5 grams, we use milligrams because it's less than a gram. So 500 milligrams. I've run out of room there, but again, mg would be milligrams, but wherever possible, try and get used to writing the unit that you're using out in full rather than just shorthand. So 500 milligrams, and if it's less than a milligram, again, so if it was half a milligram of a drug, rather than saying 0.5 milligrams, we use micrograms. So let's say we're going to give half a milligram of a drug, it'd be documented as 500 micrograms, which I'm just going to squeeze on there. It'd be documented as micrograms. So if it's above a gram, we say it's a gram, it's fine. So 4 grams is 4 grams. If it's less than a gram of a drug, it's milligrams. And if it's less than a milligram, we use micrograms. And wherever possible, try and write the unit out in full rather than relying on shortened abbreviations. Wonderful. Right, okay. So just moving on quickly now then to drug routes. Now what I thought I'd do here is have a list of all the different sort of, or some of the different ways, not all of, some of the more common ways that we come across how medicines are administered in practice. And I'm then going to match up how long it takes for these different sort of routes to take effect. So if we start off with intravenous, first of all, when we give someone a drug intravenously, we expect it to take effect in around 30 to 60 seconds. Now compare that to oral, we can actually see that taking up to 30 to 90 minutes, which can be quite surprising for some people. If sort of this is a new topic to you, a lot of people take things like oral paracetamol and expect or report a positive effect from the drug after just a few minutes, whereas actually these medicines need to digest. If you're taking them orally, they have to pass through your digestive system before they're activated and get to their sort of targeted site. So 30 to 90 minutes is where we'd expect to start to see an effect or a peak effect from oral medication, which might be surprising to some people. We've then got intraosseous, which is obviously when we're administering drugs directly into somebody's bone, and we expect that to take effect in around about 60 seconds, so only marginally longer than if we'd given it intravenously. So remember, intraosseous is where we're administering it directly into the centre of somebody's bone, which it will then sort of work its way into the person's cardiovascular system and to the heart. We've then got endotracheal. Now, endotracheal, actually, we put unknown, so it's not that common that we see it anymore, but you do hear about it a lot, where drugs used to be passed down an endotracheal tube, particularly during cardiac arrest. We've moved away from that now, although there are some drugs that are still given this way. And actually, there's a lot of variables that affect how a drug is absorbed when it's given down an endotracheal tube into somebody's lungs. So it's very, very unpredictable, and we're not entirely sure sort of consistently how long it takes to be absorbed when we give it this way. So it's not an ideal way of giving it, but you do still hear a lot. You do still hear quite it's sort of historically used a lot in people's practice, and people still refer to it quite a lot now. We've then got inhalation, so these are your nebulizers, for example, so your nebulized drugs such as nebulized salbutamol or ipratropium or adrenaline, and we look at about 3 minutes for nebulized drugs. We've then got subcutaneous, so subcutaneous would obviously be a subcutaneous injection, and for subcutaneous we're looking at about 15 to 30 minutes, which again is quite surprising, but you are administering it into fatty tissue, which isn't very vascular, so it takes time to absorb through your capillary beds and into your wider circulatory system. We've then got intramuscular, which is a little bit quicker than subcutaneous at 10 to 20 minutes. And this is because, again, you're injecting it into muscle this time. You're going a little bit deeper and you're administering it into something that's really, really vascular. We've then got sublingual, which is 2 to 3 minutes. And again, these are your sort of your buccal tablets or your buccal sprays. There's a lot of mucosa that sort of readily that means that the drugs are readily absorbed into your cardiovascular system. Rectal's another one that we do see in practice. Certainly in my own practice, we have the option to give diazepam rectally, so it's worth noting sort of how long you might expect to see that, and we look at 5 to 15 minutes for anything given rectally. Again, a little bit like endotracheal, there's a lot of variables such as from an endotracheal point of view, it'd be things like mucus buildup and inflammation, whereas rectal, things like fecal matter can obviously impact how quickly something's readily absorbed through the rectal sort of route. And then finally, we've got topical. So we're talking about our creams here, the things that we rub on skin, and they can take up hours to days to be fully absorbed. So hopefully that's useful for you, give you some ideas about how long it can take for some of these drugs to actually get to where you want them to be, depending on how you've administered them. So the next thing we're going to look at is, this is a really brief introduction into pharmacokinetics. So this is pharmacokinetics is basically studying how the body affects a drug. And actually, by understanding how a drug is, first of all, sort of brought into the body, how it's moved around the body, how it's activated or deactivated within the body, and then how it's removed from the body, can really help people who design drugs understand by tweaking these variables how sort of how to get the most out of the drug that they're giving, or making sure that the drug only becomes active or becomes its most potent when it reaches a certain part of the body. For us as pre-hospital care providers, what an understanding of pharmacokinetics gives us is actually understanding how abnormal physiology can affect how a drug is either absorbed or not absorbed, how it's metabolized or not metabolized, and how excretion could be affected, meaning it could stay in the body longer than we'd expect it to. So we start off with ADME is the sort of the system that's commonly used, and pretty much any drug you can think of, you can go out there and find the ADME for any of the drugs that you use in your own practice. But A stands for absorption, so that is literally how it is taken up into the body, so how it gets to where it needs to be, sort of how we administer it. So I've given two examples down the bottom. One is aspirin PO, so oral, and GTN, glycerol trinitrate, sublingual. And as you can see, aspirin, it's a PO, it's an oral tablet. It's absorbed in the stomach, and then sort of in the cell membranes of the cells that line the stomach. And then for sublingual GTN, you're looking at the mucosa. So it doesn't go to the stomach, it actually just gets absorbed straight through the mucosal lining. And that's the same as drugs that you give, for example, where you spray up sort of people's noses, which is becoming common for child vaccination, for example. So they're absorbed through the mucosa rather than the stomach. You've then got your distribution. So this is how it's moved around the body, and it's moved one of two ways, either through passive transport or active transport. So passive transport is where it goes to wherever it needs to go in the body, and it's just sort of absorbed. It's just moved to where it needs to be quite naturally. And we look at things like giving intravenous fluids, so using either isotonic hypo or hypertonic saline to move up or down its osmotic gradient to sort of get into the body at the right speed, at the right location, depending on what effect we're hoping to have with that particular fluid. That's compared to active transport, where active transport is where the drug actually binds to a protein to cross over into a membrane. So it's physically attached to a protein to move through the sort of the membrane, the cell, to cross over a membrane, a cell wall, into the particular target cell that we're hoping that drug will have the effect. And again, this is where the design of the drug comes in. The people who designed it need to design a drug that can piggyback onto these proteins to be able to be moved into the cells appropriately. So it's distributed either passively or actively. When it's distributed around the body and it's got sort of where it needs to be, or sort of on the way to where it needs to be metabolized. So this is where it's converted into a metabolite. Most of the time, so metabolite being the active ingredient, the thing that's actually going to cause the effect. Mostly this occurs in the liver, but it can also occur in blood plasma. It can also actually be metabolized in the kidney with some certain drugs, not just excreted that way. Some are also metabolized in the lung, in the intestinal mucosa, and also in the actual synapses of your nervous system. So there's lots of different places drugs can be metabolized into a metabolite, into its active form. And again, it all depends on the drug and whereabouts in the body you want it to have its effect. Finally, we've got excretion. So this is where the drug's removed. So it's either going to eliminate the toxic byproduct of metabolizing the drug, or actually the active metabolite itself, so the active part of the drug itself. Now, the kidneys are the primary organs here. However, you can actually excrete drugs other ways as well, such as via the lungs. That's one way that we get rid of a lot of alcohol out of our system. It's actually exhaled. And then through mammary glands as well, which is why some drugs obviously have the caution or the contraindication there for pregnancy and breastfeeding. So in terms of relevance for our practice, if you've got a patient that's got renal impairment, so sort of problems with their kidneys, it's good to know for us that actually they're going to struggle to excrete that drug. So if it's going to have a toxic effect, if we're going to cause harm with it, that harm's going to last longer potentially. It's also good to know that most drugs are metabolized in the liver. So again, if you've got a patient with hepatic impairment, with liver impairment, you're going to see some inefficiencies with how that drug is metabolized. So it's not going to sort of maybe have the effect that you want it to. So I've given sort of two examples there. Obviously, you've probably had a read of them because I've been on this part of the slide for a while now. But aspirin and GTN, and I've gave you the ADME for all of them. And like I said, you can actually find this out with all the drugs that you come across or carry in your practice. So now moving on. We're going to have a look at, I'm moving everything around again. We're going to have a look at the responses to drugs. So just very quickly, you're going to get one of three responses to a drug. It's either going to be the predictable effect, which is what we want it to do. So predictable is the desired effect, so what we want the drug to do, and the side effects. So these are the side effects that we know are going to happen. So we know that morphine's probably going to make you feel a little bit lightheaded, and it's probably going to make you a little bit itchy. So these are predictable effects. We've then got iatrogenic responses, which is responses inadvertently caused by administering the drug. So these are undesired and unplanned sort of effects that we've caused by giving you the drug. And then we've got unpredictable responses, which is your allergic reactions, and then what we call the idiosyncratic responses. These are the unreported. We've given aspirin to millions and millions and millions of people, and for some reason something incredibly bizarre has gone on after administering the drug to this patient, something we don't know about. So it's a side effect or an iatrogenic response that we really had no idea could happen. So they're your unpredictable responses. We've then got the what you can see down here at the bottom, which is your therapeutic effect and your therapeutic index. So all this is just introducing you to the terminology, really, in case you come across it in your own reading, or we're going to use it again in sort of later videos. And that's your therapeutic effects. That's the dose. So you've given a dose. So you've given a gram of paracetamol, for example, and the therapeutic effect is that you've seen a reduction in sort of patient's pain. You've then got the toxic effect. So this is when you've given a dose of the drug that's got to a point where it's now causing an overdose. It's causing harm due to the dose of the drug that you've given. And then the bit in the middle is what we call the therapeutic index, which is the range between where a medication is effective without any adverse events going on. So a drug with a really wide therapeutic index means that you can give it to this sort of degree to get the therapeutic effect, but actually you've also got a really wide therapeutic index before you get to the toxic effect, which means that the patient can take lots and lots and lots of it, or we can accidentally give too much of it, or we can keep giving repeat doses of it before we get anywhere near the point of causing harm with the drug. So that's a drug that's got a very wide therapeutic index. Now, some drugs have very, very, very narrow or unpredictable therapeutic indexes, and these are really dangerous drugs. These are the drugs where the difference between the therapeutic effect that you're after and a toxic effect is really, really, really narrow. So like I said, these are your more dangerous drugs, and these are drugs that we're going to reference. We're going to reference this therapeutic effect, therapeutic index, and toxic effects when we start talking about specific drugs in later videos. So I just thought I'd introduce you to that concept now. Ooh, we're getting there, I promise. So now, I just want to have a quick look at the lock and key theory. So this is the theory of how drugs work, basically. So it's just a really, really simple idea to sort of just think about what's going on inside somebody's body when we give them a drug. So if this here is a target cell, so let's say this cell is responsible for causing dilation of your blood vessels. So once this cell is activated by a neurotransmitter or a hormone in your body, some sort of signal sort of enzyme hits this, and it causes vasodilation of your blood vessels. And that's normally done to maintain homeostasis as part of a normal response to your body's normal functioning or response to an external stimulus. Now, when we give you a drug, we want to actually hijack this natural response and cause it to happen because we sort of want it to. But it's not done sort of through any natural sort of rhyme or reason. We want to cause the effect. So we want to cause your blood vessels to dilate. So what we do is we design and then subsequently administer a drug that fits this receptor site. So this receptor site here being a bit of a sort of a wedge shape. So if you had a neurotransmitter, a naturally occurring neurotransmitter that binded to this cell to cause it to, in this case, dilate blood vessels, we need to make a drug that's the same size and shape. So it's the same key. It's that's going to fit the lock. So this is our drug. And we give the drug and it fits into the lock, so it fits the receptor site, and then it causes the effect that we want it to happen. Now, it's important that we design the drug to fit these receptor sites perfectly to sort of cause the effect that we want or the response that we want. And what you could see here is if we gave another drug that's designed to fit a completely different receptor site, it wouldn't be able to bind to this one, so it'd completely bypass it, it'd ignore it, it wouldn't be able to bind, and it's going to continue trying to find the enzyme that it does fit to, so drug B can do whatever drug B wants to do. So you've got your drug, it's used to mimic some sort of neurotransmitter or hormonal sort of enzyme, and it's designed to be the same shape as either of those things to bind to a receptor and cause an effect. So those effects could be, for example, to reduce something, so to reduce the secretion of something in the body, to accelerate the secretion of something in the body, or accelerate one of the body's natural processes, to start a process that would normally not be starting, or to stop or inhibit a process that's causing harm that you want to stop sort of going on in the body. So generally speaking, that's a sort of, they're the outcomes that you're looking for, to either reduce something, accelerate something, start something, or stop something in the body. And we're going to do that by giving different drugs that attach to different enzymes to cause or inhibit those things. So for example, drug A might actually not cause an effect. It might actually just be designed to sit there and do nothing. So it becomes a blocking sort of drug, if you like. So it binds to that receptor site and it blocks it. And now if you had the actual natural enzyme that's sort of floating around and it wants to bind to this receptor to cause the effect that it's designed to affect, all of a sudden it can't, because there's this drug that's blocking the receptor site. So just because it's sat there, it doesn't necessarily mean it's going to cause an effect. It might actually just be trying to block the site to inhibit one of the body's natural sort of responses or effects. So that's all we're doing with drugs. And then finally, just to put a bit more meat onto that, like I said, this is the last bit, I promise. What are drugs actually targeting? So drugs actually target either the sympathetic nervous system or the parasympathetic nervous system. So that would be your fight or flight system or your rest and digest system. I'm not going to go into this too much, but it's just introducing the concept here, because when we talk about specific drugs, I'm going to refer to them as things like beta-2 antagonists, for example. All this is, like I said before, you've got these enzymes in the body, dotted around the body. Sorry, not enzymes. You've got these receptor sites dotted around the body, and we're trying to hijack them to either start things, stop things, speed things up, slow things down, etc. When we give drugs, we're trying to target either the sympathetic nervous system or the parasympathetic nervous system. But both of them are made up of these receptors, so adrenergic receptors and cholinergic receptors, or also known as muscarinic receptors. And that breaks down further to your alpha sort of 1 or 2 receptors, your beta 1, 2 or 3 receptors, or over on the parasympathetic chain, your nicotinic receptors and your muscarinic receptors. Like I said, don't worry too much about that at the moment. We're going to expand on this when we start looking at specific drugs, but just if you can get that into your sort of head, that's where when we give drugs, we're targeting these receptor sites And all these receptor sites have got different jobs in the body that we're going to try and hijack and do things with. Thank you very much for your attention. Appreciate it's been a bit of a long one, but hopefully just some of these sort of simple concepts are going to make pharmacology a little bit easier for you to understand and a little bit easier to start building upon. It can be quite a daunting subject at first if chemistry is not your thing, but hopefully this makes it a little bit easier for you. Thank you very much. If you've liked what you've seen, please give us a sort of like and subscribe on YouTube. It really, really helps us out. If you've got colleagues that are studying or students of your own, for example, please share Spear Medical with them. As I say, that sort of word of mouth really, really does help us out, and look forward to more content. Thank you very much.